pop, 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 julep, pop, 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 julep, pop, 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 julep, pop, 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 woo!
Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we answer the hard questions that often we don't have time in the office to really explore. And today, we're going to ask a really tough one. It's a question patients often don't want to bring up, either because they're embarrassed or honestly, they probably don't want to know the answer. It's a question I get much more commonly from patients' family members than from the patients themselves. It's a tough one, and I admittedly do not always have the best answer for myself. That's why today I'm so thrilled to have Dana Lowry, occupational therapist, certified driving rehab specialist from Mobility Driver Rehab, with us to help answer the really difficult question of when is it time for an older driver to give up the keys? Thank you so much for being with us today. We have lots of questions, but before we get into that, tell our listeners a little bit about you and your agency.
My name is Dana Lowry. I'm an occupational therapist who specialized in driving about 17 years ago. I hold the credentials of a certified driver rehab specialist, CDRS. And I work for a company called Mobility Driver Rehab. I see patients in Richmond, Northern Virginia, Tidewater, and Southwest Virginia at times. And I see a large number of people in different specifications for driving. So a lot of times I am seeing the older drivers that are questioning if they should or should not drive yet or drive anymore. I'm also doing pre-driving evals for kids that may be having more difficulty driving than other kids for different reasons, and all of the in-between. So if somebody is missing an extremity for some reason, we have adaptive equipment that we can get them using for compensatory strategies. And sometimes we're just doing driver training trying to use compensatory strategies. So I see across the board a lot, but it's all about driving.
Right. So when we think of bad drivers, I have a couple of teenage sons, and I think of my middle one and him being distracted. But I was surprised when I was researching this to see that drivers over 80 have actually a higher accident rate, and that the fatality rate is greatest in drivers over 85. That's pretty incredible. So at what age do most people kind of start to see some problems or think about maybe giving it up?
So complicated question.
Of course.
Age typically is just a number, but if I had to put an age on it, I'd say probably around 70. Okay. Between 65 and 70, that's when you're starting to see a lot of neuropathies. And so I get a lot of neuropathy patients that hopefully they can find our services before they run into the garage.
Oh my.
But a lot of times we get them after they hit the garage door. But when people start having reactionary issues, tends to be between 70s and 80s for most people. Okay. And there's no age for absolutely having to come off the road or having to be evaluated. But I would say that things start to be a little more difficult, like night driving, and things become more difficult between 65 and 70.
Okay. What things besides running into the garage door, which would be an obvious one, but what kind of things should a driver or their family start to look for as indicators that there might be some issues?
So a lot of the first indicators are little things like that people are forgetting, such as turn signals. You may have a driver that's used their turn signals their entire lives, and then all of a sudden you're in the car with mom and mom doesn't use turn signals. Little things like that. If you start to notice that if they start to have conversation and start to sway on the road, or maybe they're at a light and if you're talking to them and they're talking back, they don't go when the light turns green because they are kind of stopped and fixated on a conversation because they're not able to multitask. Those are the simple ones, but not using turn signals. Pressing on the gas pedal seems to be a big one, where people start to pulsate on the gas pedal, and you'll feel it in your stomach as a passenger in the car. So if you're in the vehicle with somebody, you'll typically start to feel, instead of it being just a smooth drive, like you've probably felt that person before, you start to actually notice the jolt of the feeling of driving. So little things like that. But turn signals, if they can't move their neck, they're not able to see
in our world. Yeah.
They're not able to use their mirrors really well, and so they'll kind of stop using mirrors, and that's when they're not head checking, they're not looking to the sides, they're not using turn signals. There, quite a few things, but most of the time it's the things that are missed. And then there's a whole nother level of them, like speed control. So there are some people that once they start to slow down cognitively, their 45 is 35. And 45 is just not a number that they can get to, And that's when you kind of see and you go, well, mom used to drive the speed limit, and now mom's not driving the speed limit.
Do you see it tend to be slower in most patients as opposed to faster?
So within the geriatric population, if we're dealing with the memory-based population, then typically it's slower. There's one diagnosis that I have seen that is actually the opposite of that most of the time, and that's with Parkinson's. With Parkinson's, it tends to be an impulsive move, and it tends to be an impulsive speed where they continue to jolt forward with the speed limit versus to go under the speed limit.
Oh, that's interesting. So, and of course, when you talked, about the memory issues, and we can all see how that would affect driving and neuropathy a bit. But describe a little bit more some of the factors that happen as aging that affect driving that people may not be as aware of, or things they might not recognize are actually impacting their ability to operate safely. So,
if you've ever had a parent or a grandparent, you'll hear them say, "My bones just aren't what they used to be. When it's cold, they ache. When they get out of bed, it takes them a little while to get going." When all that starts to happen, disintegration, as of bones, ligaments, cartilage, all that stuff starts to happen. And when all that stuff starts to happen, you start to lose things like neck control, or the ability to move your neck into the range of motion to all levels. You sometimes are dealing with frozen shoulders. You're dealing with shoulder injuries, torn rotator cuffs, knees that need to be replaced, neuropathies. These are all things that tend to, kind of be signs or signals that somebody is aging in a way where it may be a concern, because these are things that would hinder somebody's safety to be able to drive. So, when you start to see those things, bones start moving. And then with the vision, you have cones and rods in your visual system. And as you age, it's known that they continue to dull as you age. So as we age, the majority of people lose their depth perception completely, usually by the time they're between 90 and 95.
Wow.
I see a lot of people by the time they're 80, they don't have it. And the difference is, as they've lost it, it's different than somebody who's had maybe a blunt injury, where with our older population, they've lost it over a period of time. So as they lose it, they compensate for it. And so I see drivers often that present with no depth perception, but they still can drive and keep good distance behind other vehicles. So it's more of a learned behavior,
Right.
But it's definitely something that we do see as they age.
Yeah, I guess we didn't think about depth perception, but sure. And then hearing loss too. And it's not just you thinking, okay, you can't use your mirrors, that kind of thing. But as we age, we get arthritis in our hands. We're more likely to get carpal tunnel, which makes it, you don't have quite as strong of a grip on that steering wheel as you used to. Your knees and ankles don't maybe move as well as they used to. And that's going to, but another thing I was reading about when I was researching this was reaction time. Can you describe like what changes happen with that? Because I would assume it gets lower, but that was about all I would know.
Yeah. So reaction time tends to be delayed, and there's two parts to reaction time. There's the physical aspect, and then there's the cognitive processing. So visual motor processing or cognitive processing tends to start to decrease as you age, or as you have less activity. So think about you retire and then you're not working every day, you're not moving every day. Those muscles, those joints aren't moving, neither is that brain. So cognitively and physically, both of those aspects are being impaired over a period of time. So most people think retirement means rest, but when you stop doing an excessive amount of tasks as you would have done working full time, you're actually slowing, a lot of things down from a physical and a cognitive aspect. So reaction time cognitively, most of what I see is visual motor processing delays. So when somebody can't see and process what they're seeing at the same time, that causes a delay. That delay then counteracts with the delay of getting a foot from one surface to another surface, which is caused by the brain, of course, but also by those bones and those muscles being able to fire fast enough in order for them to react quick enough to go from one to the other. So there are two components, and one of them, people sometimes think, well, it's just a gas and brake, like as long as you can get to the gas and brake, but the cognitive processing piece is what actually prompts that getting from the gas to the brake on top of multiple other tasks while you're driving. So,
and something we hadn't touched on yet, but all the medications that people tend to be taking, it seems you know a lot about that, right?
Oh, yeah.
As people get older. And, it's not just the classic thing I think most of us would think about is an opiate. But that's not just it. The pain medicines like the gabapentinoids, muscle relaxers, and then even blood pressure medications, beta blockers, things like that, they all slow you down a bit. And if you're already a bit delayed, that could be a make or break type of situation. So you get to figure that all out too, huh?
Well, as well as like sleep apneas and different things. Because that's the other thing too, is there are a lot of times where we see clients that, use CPAPs but aren't CPAP compliant. And so over a period of time, their processing starts to delay and they go back on their CPAP and it actually starts to improve again. So medications as well as adaptations in other ways too. So there are a lot of factors to our cognitive system.
That's why we've got you here to answer these questions. So some things are obvious to me as a doctor. When someone comes in and says, hey, I think, I want you to talk to mom. I don't think she should be driving anymore. It can be obvious to me if mom's got some dementia. We know that that's going to be progressive. It's not going to typically get any better unless there's something reversible. It's usually not. And so I can say pretty confidently to those people, okay, it's time to stop. But are there other things that maybe aren't as clear of no-goes for driving and that there might be some adaptations or workarounds for?
So there are. When you talk about physical deficits, which from an orthopedic standpoint, there are a lot of injuries or a lot of deficits that the older population tend to have that could potentially be reversible, such as a shoulder that doesn't have the correct range of motion due to an injury or a frozen shoulder. Those things are typically fixable with PT. A neck, if you have somebody who doesn't have full range in their neck, they might not be able to see their mirrors now, but getting as much range as they can with physical therapy would be something that they could do to improve. On top of physical therapy, as far as adaptations for me, if I see patients that are kyphotic, that's another thing where they, again, could go to PT, but if I see them where they're contorted in a way that they're not able to see the areas they need to see, we do have wonky mirrors. We have panoramic mirrors. We have the side view mirrors that, we can teach them how to use appropriately. And it will allow them to see blind spots in areas that they maybe couldn't see previous because of a limitation. Mm-hmm. So there are things like that we can use. And then if you go into adaptations with other things like neuropathies, if you have, a client that doesn't feel their feet, obviously shouldn't be using their feet. So, the option is don't drive, or is there a workaround? The workaround for that would be a left foot accelerator or hand controls. If you have somebody that really, really has a shoulder limitation and it's not going to be fixable, a spinner knob on the steering wheel or a signal extender, which goes over the steering wheel onto the other side for that right-handed driver, would be something that we could incorporate that could allow them to continue to stay safe driving, but we wouldn't have to, it wouldn't take a lot of work to get them back on the road or continuing to drive.
Great. It's nice to know there's some options there, right? So if an older driver or their family is having concerns, How do they seek out a driving eval? What do they look for there?
So the organization that credentials me is ADED, ADED. That is the organization that certifies us as certified driver rehab specialists. We work under their code of ethics. They have a website where they have a search option, and you can get onto the website and you can search by state, and it'll come up with everybody that's credentialed to do what I do. There also is a DMV list of everybody in the state that does what I do. And you can Google DMV CDRS list, and every practitioner that's certified to do what I do will come up. Okay. So if the physicians know about us, they just have to send a referral, of course. And then we call the client and we get them scheduled.
So what does that eval look like?
So it's kind of a two-part. The first part is a cognitive evaluation. I'm looking at very, very specific things that pertain to driving. So I tell the client usually it's very similar to a neuropsychological evaluation, which many of the people that I see have had one already. And, it's not as long, where neuropsychological evaluations tend to be a little lengthy on the multiple hour side. But the standardized tests that I use are similar to that of a neuropsych eval, but I'm looking very specifically at the things needed for driving. So I'm looking at visual motor processing speeds. I'm looking at divided attention and undivided attention. I'm looking at memory, short-term and immediate, mostly. I'm looking at the visual portal system, and I'm checking their vision to see, one, what their acuity is to make sure they're legal. A lot of times I'll get people from a visual standpoint that haven't been to the eye doctor in 5 years, and they come in to see me, and we can't get past the clinical portion of the evaluation because they have cataracts and they didn't have it addressed. They just thought they were going blind and didn't want to tell anybody.
Oh, no.
So, we stop there. They get the cataracts removed. They come back and see me for the rest, But the visual portal system is a complex system. So I'm looking at, how well their eyes are tracking, if convergence looks good, if they're able to fuse on an object at the same time with both eyes. These are all things that we need in order to drive safely. So all the things that I'm looking for are directly related to driving. And once we get done with the cognitive portion of the test, we go to a company vehicle that has a brake on the passenger side for safety, and we let them drive. And we take them on a course. If I have someone who says, I never drive on interstate, and I'll say, well, that is a restriction that we can place on a license. But if you don't want to go on interstate, then I won't put you on interstate. But I try to put them in an environment, or if I can do a local area, I'd prefer to do a local area. But if not, I try to simulate the environment that they would be driving in. Mm-hmm. For example, I saw a patient this morning who only drives within his local area. He lives in Williamsburg. All the roads in Williamsburg are 25 and 35, within probably a 10 or 15 mile radius of his house.
I know. I've gotten tickets there before.
Yep. So for him, his goal for driving when we started was he just wanted to be able to drive in his local area. He didn't care if he was allowed to go on interstate. He didn't care if he had night driving. He didn't care if he had anything else. He just wanted to be able to go within 5 or 10 miles of his house. So we drove. He had actually had an accident, which is what prompted him to come to me. We drove and went to the accident site, actually, where he had had the accident, so I could kind of figure out what had happened. And it was just a small mishap that anybody could have done. So, of course, he was of a geriatric population. His age was 82. And so they, I think, kind of flagged him for, how did this happen? Well, you are a little bit older. Let's get a medical report. And so, when I saw him, all he wanted was to drive in his local area. So we went and we drove all over his local area. I couldn't find a road around him anywhere that he goes, of all the places that we went to, that were over 35.
Right.
So when we were done, I granted him 35 and under, and within 10 miles of your radius, so that those will be legal restrictions for him, but he's happy with that. He's happy to drive just in his local area. So I love to be able to do that when we can.
Now, how say it doesn't go as well,
Unfavorable.
unfavorable outcome. How do you broach that conversation?
I tend to be very transparent. I feel as if somebody has come to me for a purpose, and the purpose was for me to do an evaluation. And as a practitioner, part of that evaluation is to respond and give results. I believe that that's only fair. If somebody is coming for a service, it's only fair to tell them what the outcome of the service is. So I approach it lightly, but typically after we've done the driving portion of the evaluation, I discuss with them. And normally I just start by asking, how do you feel like you did? How do you feel like you performed? And, I'll say, well, let's start at the beginning. The clinical portion, how do you feel like that went? How do you feel like you scored on those things? And usually they can point out a couple of things that they may have done wrong. Then we get to the driving portion and I'll say, well, how do you feel like the drive was? And interestingly enough, by the time we get to the drive, most of them go, oh, I did great. So, but the drive gives me the ability to really, really explain to them why I feel like things are unsafe if they're unsafe. I can say, well, there was a stop sign at that road. Do you remember the stop sign at that road that you didn't really stop at? Do you remember how many times I had to put my hand on the steering wheel to get us back into our lane? The speed limit on these roads was, 45, yet you never reached over 27. And usually that immediate recall kicks in and they're able to remember those things because it had just happened. And so, I kind of start the conversation with that and just kind of explain to them why I feel like it's unsafe and how it would be unsafe for the people around them. It would be unsafe for them. It would be unsafe for their family members if they were in the vehicle with them. And most of the time, even if they're upset with me about an outcome, they're crying and they're hugging me on the way out, So I try to be as empathetic as possible, but I also try to be as transparent as possible. I think that's only fair.
Well, once you know what the problem is, then you can work towards the solution.
Yeah.
So that brings me to say it's time. You can't safely drive anymore. How do you navigate that loss of independence? How do you still get to the doctor? How do you get your groceries? That kind of thing.
Hopefully there's a support system.
Yeah.
I have evaluated many, 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 many people that don't have children, don't have nieces, don't have nephews, don't have cousins, families already gone.
Right.
Friends have passed before they did, So hopefully there is a support system. If there's not a support system, it's a lot harder to navigate. And there have been times where I've had to get like adult protective services involved so that we can get attorneys in to certain situations for those. But in general, I would say the conversation starts in my office when driving is no longer a thing. Driving is the key component to continuing to be independent end of life. So when you take driving, all of the other conversations that come after that are instrumental ADL related. Those are all the things like money management in medications, home management. These are all things that have to happen safely in order for someone to stay independent. And driving just happens to be the one that usually gets pulled. And then other people see that there are difficulties with the other ones. So most of the time that conversation starts with driving. Many times, even in my office, if there is a support system, a lot of times in my office is where it starts. And we start talking about resources and we say, well, have you thought about moving to independent living? Have you thought about have you been to visit any of your friends that are in assisted living anywhere that you might be interested in moving to? Or what about caregiver services? Let's talk about what our resources might be for caregiver services and just get somebody into the home to help you. How much care do you need? Right. So those are all conversations that typically start in my office and just kind of progressively move from there. As far as resources, Virginia has the state, it's actually AARP and AOTA, which is the Occupational Therapy Association. They have collaborated together and come up with the Virginia Grand Driver Program. So the Grand Driver Program is a program that offers a grant for a discounted cost for evaluations. And it's issued to, I think the limit this year was 35. So 35 individuals within the course of the year can use it as discounted to be evaluated. They also have a website that has community resources. So if you get on the Virginia Driver website, they have a questionnaire that a client or patient can take themselves that gives them some of the safety concerns, has anybody said they're not going to ride with you anymore? Has anybody commented on you, swaying from your lane? Those types of things. It's a checklist so that maybe if there is good insight, they can kind of take the checklist. It also has, for caregivers, it has, a lot of lists of things to be on alert for, so that if you're not watching this podcast or listening to this podcast, you would have a list of those things. But the community resources is nice because it's a navigation system. So you use a drop-down menu on their website, and it allows you to go into, are you looking for caregiver services? Are you looking for transportation services? Are you, looking for a day program? It does have all those, and anything that the state has been able to identify as a proper resource is going to be on that website. Okay. So there's also a thing called CarFit. And CarFit is through the Virginia Driver Program as well. And a lot of times that's where the conversation starts about driving, if we can get them to a CarFit event. CarFit is an event that is put on by volunteers. A lot of times there are OTs or CDRSs like myself that go. It's all volunteer, but it's a community-based event that people can host. And it's an educational program for really kind of ergonomically setting somebody up to make sure that they fit in their car. So I've seen over the years little tiny ladies that are sitting on 3 cushions from their couch. That's not really that safe, So it allows us to kind of go through the vehicle options, explain some things about the vehicle that they may not have known, like how to check their tire pressures. If you're a widow and you've never had to maintain a car, then you probably don't know anything about a tire gauge or how much air you're supposed to have in your tires, or when you're supposed to actually replace your windshield wipers, or how to figure out what size your windshield wipers are. Yeah. These are all easy things, but we go over a lot of those things within CarFit, as well as we look at the driver in the seat of their space, their driving space, and we look to see that they're 10 inches from the steering wheel. And if they're not, is there a modification that can help them? Is there a proper cushion that they could put behind their back, or a proper cushion that they could, use to sit on? Are there small accommodations that can be made? So CarFit is a really, really good community-based resource that works through the Virginia Driver program, but it's kind of its own entity. It's community-based, it's volunteer-based, but it really is sometimes where the start of, are you having some difficulties with some things, and kind of bringing that insight up to the client. And that's when they start kind of thinking a little bit more about the proactiveness of driving, And if they are having a lot of difficulty, we can talk to them when they're at CarFit about what that looks like, or that maybe they should be evaluated, or that they don't need to be evaluated. They just need to, follow the recommendations that we gave them at CarFit,
So that kind of brings in, because that slides into how do you bring this up to people, So I see how you can bring it up through that. And certainly I will get family members in with patients, and they kind of throw it to me. Yeah. Hey, doc, you be the bad guy, which I will. It's okay. But if they don't have one of us to prompt it, how does family start that conversation?
So there are a couple of resources. Thehartford.com, it's an insurance website, but they actually have a vast amount of educational resources and brochures. Of the driving related ones, there are a couple of them. One is directly related to dementia. There's another one that is related to the pathway of driving, kind of knowing when to talk about it, when not to talk about it. So that's a good one for caregivers. And then there's one about when when is it really time for the keys to come, and those resources are great because they are like workbooks, and you can kind of work through the book with that person. And if they are insightful, they will have the ability to look at some of these worksheets that they're kind of working, because it's self-awareness, and they'll be able to see those things. And it's easier, I think, for the caregiver to be able to have that conversation while they're in the middle of doing something like that. Otherwise, bringing it up, in my professional opinion, bringing it up with a lot of people that might be having difficulties, if the insight is not very good, bringing it up will just anger the patient, and it will make the patient target the caregiver. And I see that very, very, very often. The person that says, Mom, you shouldn't drive, that's the kid that gets taken out of the will, or loses power of attorney, and, the patient will come in and they will talk to me and say, well, they don't want me to drive. They don't want me to do this. They don't want me to do that. And I try to explain to them, you're like a precious egg in a basket. You are our parents. You're our grandparents. Right. We want you to live forever, So when we see things that are concerning, it's not that we're being malicious and with intent. It's because we want you to live forever, and sometimes they understand that and sometimes they don't. But it is much harder for caregivers to bring up driving than it is realistically to bring it up with the physician and for the physician to just refer it to us. Because a lot of times we end up being the bad guy, which I'm okay with, because a long time ago I made a promise to myself that if I ever felt like there was a thought that I had where, if this person lived in my neighborhood, could my children play in the road? And if I was on the fence about if it was favorable or unfavorable, if I could sit back and have the insight to say, after the drive that we just took during this evaluation, if my daughters were playing in the road, playing basketball in the road, and had to move every time a car came, or say a ball, ran out into the road and they were going to go get it, if this person lived in our neighborhood and drove in our neighborhood, would I want them driving in the neighborhood with my children? And if the answer to that is no, the answer needs to be a no. So those ones that are kind of the just in case, where they did some good things and you're really rooting for them, but it was enough to be unsafe, that's the question I asked myself. And it's not just the safety of the patient, it's the safety of the community as well.
That's right. It's not just them as our precious cargo, as the older patient.
Driving.
It's other people's precious cargo that we have to be careful about too.
But it is hard for family members to bring it up. It's actually much easier for them to just refer it to a physician and the physician to refer it specifically, because then, even at that, the physician becomes the bad guy, which some physicians care, some don't. But I feel like it shouldn't be the physician's responsibility to do that, because you have a good relationship with that patient. And I wouldn't want a good, long relationship with a patient you maybe have seen for years to go bad or to be a negative thought based on one entity of their life. And I've seen it happen, So instead of them firing their doctor, I would much rather them get the results, from me, go back and see the doctor. The doctor talks to them about the results, and they continue that relationship, and treat them appropriately.
And it's much better to have some objective data, and scientist at heart, right? And you like to have that objective data to say, this happened, this didn't happen, as opposed to, well, my son just thinks I'm a bad driver or whatever, or they just think it's because I'm getting old. Right. And it may just be someone's being hyper cautious, or it could be that there's an actual problem, and having that objective data lets us all be on the same page.
Well, to go with that, I would say I see a lot of people that kids will call for their parents and they'll say, my mom got diagnosed with dementia. She should not be driving.
Right.
And I'll ask why. What is it about their driving that makes it unsafe? Well, I don't know. They have dementia. They just shouldn't drive. And so educating the caregivers is just as big of a deal because, again, if it's somebody that's newly diagnosed that still has years and years and years of safe driving, within their wheelhouse, I wouldn't want them to come off the road just because a family member feels uncomfortable. I would rather have the evaluation, have those objective tools, and then educate the caregiver,
Right.
Educate both of them at the same time.
Thank you so much for being here today. I feel much better
You're
equipped
very welcome.
in how to answer this question for people. So then thank you guys for joining us today. This is such a challenging subject since aging, while universal in some ways, is experienced quite differently, with some people having some age-related challenges earlier in life. We don't have a specific age at which it's no longer safe to drive. But we can say that after 70, it's probably more challenging, and being cognizant of those challenges and how to adapt is going to help older drivers stay safe. We hope you learned something. Please rate this podcast and subscribe. We don't want you to miss out on any of our exciting new episodes. Until next time, wishing you good health. See you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.